Hi, my name is Gretchen McNally. I'm a nurse practitioner scientist at The Ohio State University James Cancer Hospital. Thank you so much for the invitation to talk about my poster. Before I do that, let me tell you a little bit about my background. I am a hematology nurse practitioner. I'm newly into this nurse practitioner scientist role. It started in September of 2024, and so I decided, because my clinical work was largely in an immunodeficiency cancer clinic, working with people that have HIV, solid organ transplants, autoimmune diseases, things like that, I really got interested in stigma. And so I went back to school for my master's in public health, was able to do a deep dive in cancer-related stigma, working with Ellen Carr from the CJON, Clinical Journal of Oncology Nursing. And then for my final project for school, I was looking for a stigma-related something, and I reached out to Dr. Electra Pasquette, who's really well known in the cervical cancer world, which as a hematology nurse practitioner I had no experience with, but Dr. Pasquette hooked me up with the American Cancer Society Cervical Cancer Stigma Work Group. And so I was able to work with them. I actually wrote their white paper. I did a white paper for them, and that was my final project for school. So what I love about stigma, although I guess you shouldn't love stigma, but it's really my area of passion, it's really agnostic to cancer. There are some things that are like specific to cancer type, such as cervical cancer, but I can really, go all across the oncology world and incorporate it. So that's kind of how I started. So the American Cancer Society came out with a National Roundtable on Cervical Cancer in 2022 when President Biden relaunched the Cancer Moonshot. And they did a member survey or questionnaire, and anyway, stigma was identified as one of the barriers to care. So the National Roundtable on Cervical Cancer formed a stigma work group. So I worked with the stigma work group, and that was really made up of people that were either cervical cancer survivors, caregivers, advocates, and I came in and I did their white paper for them. And a white paper was something that I was not really that familiar with, but what it is it's kind of like an informational kind of review, and then you come out with like a recommendation for the future. So I did a review. I found a model to kind of use to guide the stigma research. It was something I had looked at earlier when I worked with Ellen Carr, the Health Stigma Discrimination Framework, which is multi-level. So cervical cancer is largely stigmatized because of the association with the HPV virus, or HPV, which is human papillomavirus. And so that actually was identified as the cause of like 99.5% of cervical cancer in the early 1980s. But it really became well known when the first HPV vaccine came out, I think in like 2004, in part because of the poor marketing, I feel. They marketed it only for women or females like age 26 and under, and they associated it with HPV infection and genital warts. So right there, you can start thinking of why there were a lot of stigma with that. And then a couple years later, they added males to that, 26 or younger, again for genital warts. It wasn't until 2014, when Gardasil came out, that they actually started marketing it to prevent HPV-related cancers, 6 different types of HPV-related cancer. And then in 2018, they increased or expanded the indications for people under 45. So for my review, there was only a couple of studies, which I classified the review as past, present, and then future, which was my recommendation. And so past, there was only 2 articles, which basically showed how there was a negative association with people having cervical cancer. People had less compassion, more blame. They blamed them. They thought it was related to sexual activity, which is not really true. I think something like 80% of all females, 90% of all males have been exposed to HPV. And so then when we looked at the current research or articles published, most of those were descriptive. Only one included a reduction, an intervention to reduce stigma. And what they found from that is that it was important with how you framed it, because you didn't want to they found that while it increased screening, it increased screening, but it also increased the public perception of stigma for people that had cervical cancer. So that was kind of not intended. There's a really great paper published out of Australia that said that we should really start using universal guidelines, universal precautions, for all stigma. And what that means is, like, universal precautions, if you're not aware, really started when HIV started in the early 1980s. Before then, you didn't wear gloves, but then, since then, you weren't sure who had an infection. So when you were exposed to any bodily fluid, now you wear gloves. Like for me, I've always worn gloves because I was not a nurse. I was not that old in 1980, so it was gross. Like, why would I want to handle someone's bodily fluids or whatever without gloves, right? But before, they never wore them. So universal precautions, using that as the framework, and then using language and applying that, like, so everyone you treat with appropriate non-stigmatizing language, regardless of if they have HPV infection or cervical cancer or HIV or any other cancer, regardless of their race, education, blah, 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 gender. I think that's a way that we can start reducing stigma, and it should be fairly easy to implement from all the levels down. We just start changing the language when we talk about it, depending on the situation. But some people, they're denied care, they're called names, they're asked really embarrassing questions, they might be physically assaulted. I mean, it's hard to think as an oncology nurse that anyone could treat anybody else like that, but it's true, and it really happens. And research, mostly coming out of addiction, but can be extrapolated to oncology, shows that the words that we use affect the clinical judgments that clinicians and decisions that clinicians make, which then impacts the care people receive. So I think by changing the language, people, they won't be so afraid or scared to go present for care if they feel safe, in a safe environment. I know in my personal clinical practice, I have patients that come and see me, even though I'm their hematology nurse practitioner, right? I'm managing them for their cancer, but because of their substance use or other HIV issues, that they don't feel quite as safe, or that they receive the best care from other providers. So I think that by implementing these guidelines and everyone kind of adopting stigma-free language, more people will present, will get screened, will receive the care that they need, and outcomes should be better.